dear audience. Thank you very much again for the opportunity. After this very nice introduction, I would like to present you two of our ongoing trials about acute pancreatitis in a little bit different topics. The first of it is the EASY trial. Everybody knows that the acute pancreatitis is quite a common disease, but can be associated with significant morbidity and mortality. So that's why the assessment of the severity is absolutely crucial in the management of the disease, because we know that the patients who are at high risk for severe disease require much closer monitoring and an immediate and more aggressive treatment for that disease. Why do I say that? Because we know that however the proportion of the severe disease is relatively small, 15–20%, but if there is a severe disease with an infected necrosis, the mortality can reach even the 70%. So acute pancreatitis can be a real severe disease. What to do with that? So that's why if we would have a scoring system when we can determine the severity of acute pancreatitis in an early stage, it would be very challenging. Unfortunately, there are multiple individual risk factors for severe acute pancreatitis, but we do not know the role of that individual factors till that time. We have also numbers of predictive scoring systems. Ranson score is known for everybody. The problem is that Ranson score is about the first 48 hours to be completed. So in reality, we are missing the early therapeutic window for doing anything with the real severe disease. The Apache score is mainly developed as an intensive care tool and requires a huge amount of parameters, so quite difficult to deal with it, and sometimes not relevant absolutely to the prognosis of the acute pancreatitis. The two other scoring system has also some problem. To tell the truth, it's not widely used in the daily routine, in the general practice. So that's why our hypothesis was that if we would be able to recognize early the severe acute pancreatitis with a simple, easy, and accurate clinical scoring system, then probably we would be able to prevent serious adverse effects and improve the treatment and the management of the patients and hopefully the overall clinical outcome as well. So the aim of that ongoing study is to develop a simple, easy, and accurate clinical scoring system that can be performed also in small hospitals with limited access of diagnostic tools, and which can stratify patients with acute pancreatitis during the early stage of the hospitalization according to the risk for severe disease scores. How to do that? It will be an observational multicenter prospective cohort study, of course, for adult patients, men and women, age 80 to 99 years, who were hospitalized due to acute pancreatitis. We have already a Hungarian National Pancreatic Register, which was introduced by Peter previously, which can be used for that ongoing study. And of course, we have all the ethics and the registration for that. How to do the registry and the enrollment of the patients. The patients who are required to participate in the ongoing study is hospitalized due to acute pancreatitis. And the diagnosis based on the fulfillment of 2 out of 3 criteria according to the IAP and APA guideline, which was published in the Pancreatology 2013. It is important that the patient's disease is regardless of the etiology. And we accept mild, moderate, and severe pancreatitis, of course, as well. The target number of the patients is 1,200. We collect data, simple, attainable potential prognostic parameters at the admission. Of course, we register the medical history, the physical examination, laboratory test, diagnostic testing. You will see the forms what we would like you to fill out. and afterward, the individual statistical analysis will be performed of each parameters to assess its potential correlation with the severity of the disease. I don't want to go into the details. These are the parameters what we would like to use: history, all the laboratory parameters, the physical examination of the state of the patient, and the most important diagnostic imaging findings of the patient. Afterwards, we try to utilize the selected parameters with the potentially severity prognostic markers, which can show the strongest correlation with the severity of the disease. And of course, we need to compare of patients' clinical course with the obtained results of an early risk stratification planned with 300 patients. At the end of the study, we plan to validate or easy index in case of the correlation of patients' clinical course with the obtained results of the prospective early risk stratification. Our plan is to reach 5 to 10 relevant parameters which can determine the severity of the disease. There are the application forms that you have seen previously by Peter. We have also, as he mentioned, in Russian language as well, so probably there will be no any problem with the translation. There is a special questionnaire for the patients as well, and all the parameters what I mentioned previously can be uploaded to that questionnaire. Another topic, it is required, or it would be really great to be able to collect blood samples, tubes from the patients and deliver or ship it to Szeged in minus 20 degrees for further potential genetic studies which can result in an interesting results in the genetic testing of acute pancreatitis. So summary, by assessing the ability of the selected markers for prognostication of the acute pancreatitis, the goal is to establish a new, simple scoring system, the early achievable severity index, which can show probably more information about the severity in the early stage of acute pancreatitis. The other trial what I would like to present you also is about acute pancreatitis, but a special form about the acute biliary pancreatitis. And we would like to examine the preventive pancreatic stents, the role of it in the management of acute biliary pancreatitis. We know the epidemiology, we know the incidence mortality of the disease. This is really a severe problem. There are some significant publications known by everybody for sure. One important question in that topic, that what is the indication for an ERCP and sphincterotomy early in the course of biliary pancreatitis? We have seen a lot of presentations today and yesterday about that topic, so it's quite clear that I would like to highlight that ERCP is probably indicated in biliary pancreatitis with common bile duct obstruction, and ERCP is indicated patients with biliary pancreatitis in case of cholangitis as well. This is the pathophysiological background of that, also known by everybody. Our study group already published a non-randomized study about that topic, which was about 141 patients in two groups, divided stented group and the control group. The indication of pancreatic stent insertion was severe papillary edema due to impacted gallstone, more than 5 times pancreatic duct cannulation and filling, or difficult common bile duct cannulation, or if there was a needle knife papillotomy necessity of the disease. And what was interesting, what we found that in the pancreatic duct stenting group, the morbidity was significantly smaller than in the control group, indicating that probably the preventive pancreatic stent can have a role in acute biliary pancreatitis. So after this publication, our aim is to organize a randomized prospective controlled multicentric study, interventional study for proving that evidences. Our hypothesis is that the maintaining the outflow of the pancreatic duct with this preventive pancreatic stent in the early ERCP improves the outcome of the acute biliary pancreatitis. We think that this trial can change the current acute biliary pancreatitis treatment guidelines and suggestions as well. How to join it? Almost the same like the EASY. There is a letter to intention to the participants, also translated to Russian, so every hospital can join that program. Our target number of patients is 230. The length of the study is planned for 4 years. There are several participating centers from Hungary as well and from abroad. Altogether for that trial, more than 40 centers signed in and would like to join that study. The inclusion criteria are the diagnosis of acute biliary pancreatitis, I will talk about that, above 18 years, and the possibility of performing ERCP within 48 hours calculated from the onset pain, and of course the written informed consent is necessary. The exclusion criteria are quite typical in that study. How to do the diagnosis of the acute pancreatitis? I've already mentioned previously 2 out of 3 criteria for abdominal pain, serum amylase or lipase elevation, or any characteristic findings on the imaging studies. It is important to determine the biliary origin of acute pancreatitis as well, which is based on the criteria by the Dutch Pancreatic Study Group. If one of the following 3 definitions is present, so gallstone and/or sludge diagnosed on the imaging. If there is no any definite gallstone or sludge, but the indirect signs, dilated common bile duct is present on the ultrasound, or if there is a significant elevation of the obstructive parameters in the lab test. So all patients will be assessed for eligibility. As the second part of the protocol, we have to start goal-directed intravenous fluid resuscitation, which has a high evidence in acute pancreatitis as well. And afterwards, we have to assess the cholangitis and/or the cholestasis as well, do the randomization, do the intervention, and do the further treatment. The presence of the acute cholangitis will be assessed at the admission based on the Tokyo guidelines with a small modification, because the Tokyo guidelines mentioned that from these 3 criteria, the ABC criteria, 1 item in A, 1 item in B, and 1 item in the C group should be fulfilled. We modified a little bit, so the definite diagnosis both A and only 1 piece from the B and 1 piece from the C group is required. The evidence of the cholestasis is also diagnosed by the imaging and the laboratory markers. If there is objective demonstration of gallbladder stones and/or sludge, or dilated common bile duct, as I mentioned, or common bile duct stones on the abdominal ultrasound, and elevated liver function test, and the bilirubin level is more than 1.5 times elevation. This is the protocol for the examination, how to include and exclude patients for that study. If the patient has an acute cholangitis, then the randomization will happen, and we'll do a ERCP or the ERCP together with preventive pancreatic duct stenting. If there is no any cholangitis, then we have to assess if the patient has any cholestasis according to the previously mentioned parameters, and if there is, then we can do the randomization into a conservative arm, into a ERCP control arm, and into a preventive pancreatic stenting arm as well. If there is no any sign from cholangitis, of course, we have to exclude that patient from the study. So the primary endpoint of that protocol is the outcome of each group will be calculated using the composite endpoint, which means that moderate and severe acute pancreatitis, any complications include the systemic complications and also the local complications as well, according to the Atlanta classification, and of course the mortality can be an important endpoint. There are the secondary endpoints related to the acute biliary pancreatitis, multi-organ failure, mortality rate, pain score, new onset of sepsis, the proportion of patients with severe acute biliary pancreatitis, the portion of patients with severe organ failure, and there are secondary endpoints related to the endoscopic treatment as well. You can see on the slides. I do not have, unfortunately, enough time to talk about that.